Good afternoon, everyone, and welcome to today's webinar hosted by Better Medicare Alliance's Center for Innovation in Medicare Advantage in cooperation with Avalere Health. I'm Congresswoman Allyson Schwartz, the President and CEO of Better Medicare Alliance. I want to thank you for joining us. Hope you've heard me. Okay, thank you for joining us for today. And on behalf of Better Medicare Alliance's community, we're really very hopeful that glad you're here and hoping that you are staying safe and healthy in the ongoing COVID-19 pandemic. Today's webinar serves to unveil our new research on high-need, high-cost beneficiaries in Medicare and Medicare Advantage, and the important role that Medicare Advantage plays in providing high-quality, value-based care to beneficiaries. In just a few minutes, you'll get an in-depth look at these findings from Dr. Christie Teigland, principal at Avalere Health, and the lead research on this project. But allow me just a few moments to give you some of the biggest takeaways. Let's start with preventive services. Medicare Advantage beneficiaries are screened for depression, breast cancer, prostate cancer, and received a risk falls assessment at higher rates than traditional fee-for-service Medicare. And at a moment when the nation is on the precipice of safe and effective COVID-19 vaccines, this report offers telling numbers on vaccine rates in MA. The findings show that Medicare Advantage beneficiaries receive pneumonia vaccine at 49% more often than those in traditional fee-for-service Medicare, and receive the flu vaccine 11% more often than those in traditional Medicare. For elderly beneficiaries had 66% more outpatient visits than those in traditional Medicare. And beneficiaries with major complex chronic conditions had a 57% lower rate of avoidable hospitalizations for acute conditions than those in traditional Medicare. Costs for primary care were 41% higher for beneficiaries with major chronic conditions in Medicare Advantage, implying high utilization from primary care. Overall, this report also showed that MAPD plans combined achieve better outcomes at 15% lower costs, enabling plans to invest in the care management and in additional resources and in lower cost sharing for beneficiaries. This report shows that Medicare Advantage prescription drug plans are working. This is not lost on any of us that as we release this report, there are big changes happening in Washington. We'll soon have a new president, and we look forward to working with President-elect Biden and the incoming Secretary of HHS, who was just announced yesterday, a good friend of mine, Javier Becerra. We will seek to keep, as we continue to do, Medicare Advantage secure and strengthen the policies that allow MA to provide the care you'll hear about today for beneficiaries, including those that are at the highest risk: frail elderly, disabled, and those with complex chronic conditions. We've worked with the current administration really well and with the previous administration, so we look forward to this next 4 years. We also have a new Congress, and we're very excited to continue the momentum that we saw this year with a record number of 75% majority, 75% of congressional support for Medicare Advantage. This report will be very much a part of our advocacy work in 2021. Given the fact that it has so much evidence of Medicare Advantage's improved outcomes, really suggesting that the use of care management, the focus on prevention and outpatient services, and primary care are really making a difference for beneficiaries. It's our hope that these findings really make an impact. I think you'll help us to talk about them in showing that Medicare Advantage is achieving better outcomes at better cost. It's something that's talked about a lot. We keep hoping it's possible, and it's fact that it's happening today under Medicare Advantage. So just a note before we begin the presentation, and that is that you want to ask a question of Christie Teigland, today's presenter, or for me at the end of the presentation. You're going to ask a question at any time using either the chat function or the Q&A. Questions will be read aloud by one of our team, Deborah Estes, who's policy director, at the end of this program. So we hope we have enough time for all the questions. If not, we'll certainly get to them offline after the webinar. If you are a reporter, and we have several reporters on attending this call, by all means you can ask a question, but please identify yourself as a reporter when you ask that question. So now I'm very pleased to welcome Dr. Christie Teigland to provide a deeper review of this research. Just a little background on Dr. Teigland. Before joining Avalere, she was Senior Director for Statistical Research at Novolon, where she led a team focused on healthcare data analytics. She led several performance measure development projects, including the all-cost readmissions and potentially avoidable hospitalizations report. She also was lead research on a prior report from BMA in 2018 on outcomes for beneficiaries with chronic conditions. So, with that, we have an expert with us. We're delighted to work again with Dr. Teigland and look forward to her presentation and to your questions and comments. Thank you for being a guest today. So, Chrissy, over to you.
Sorry, I was talking away on mute. Let me start over. Thank you, Congresswoman. I'm very pleased to be here today. This topic has been a passion, particularly the study. We were able to pull in social determinants of health, which is a passion of mine. I serve on the National Quality Forum Standing Committee on Disparities and also on their scientific methods panel that looks at social risk adjustment and disparities. We were actually able to pull in some of that data to both the Medicare Advantage and fee-for-service populations in this study. So without ado, we will move forward. As you all know, Medicare Advantage, managed Medicare Advantage plans have incentives and they have flexibilities and tools that are different from Medicare fee-for-service. And we really wanted to develop some quantitative evidence demonstrating whether these tools and flexibilities really do drive better care, really do drive lower utilization of hospitalizations or readmissions and so forth, really do impact quality outcomes. And so we will present a wealth of findings today comparing these two populations. One of the critical things that we did in this study that is different is that while we first evaluated the overall populations, because it's important to understand who's in Medicare Advantage compared to who joins traditional Medicare fee-for-service, we, for purposes of the analysis and comparisons, we actually did propensity score matching. And so for every Medicare Advantage member that we had data on, we actually matched that to a fee-for-service member. So we built also upon a study framework that was initially developed by Joint et al. The reference is below. It was a study conducted for the Commonwealth Fund that segmented high cost, high need Medicare fee-for-service patients into potentially actionable cohorts, distinct cohorts, clinically meaningful, distinct cohorts, and to really isolate those patients who are most high need, high cost. I actually had a follow-up study with the Commonwealth Fund where we applied that same approach to the Medicare Advantage population for the first time. And so we've now implemented that here, but we are actually using a propensity score matched, cohorts so that we're comparing Medicare, beneficiaries, apples to apples, patients who look alike. And so we then developed an in-depth descriptive profile of the whole populations before we did that matching. And we also, including social determinants of health, the prevalence of social determinants of health in this population. And we'll speak to that data in a moment. The analysis that we did, the comparisons that we did, though, were on those matched cohorts so that we truly were comparing similar patients, so that we're looking at outcomes, we're looking at costs, we're looking at quality measure rates based on people who look the same, people who look alike, and within then those high need, high cost cohorts. Next slide. So our data sources were, first of all, our parent company, Avalere's parent company, Inovalon, where I worked. I've been with the company for about 9 years now. It has a very large database. It's called the Medical Outcomes Research for Effectiveness and Economics. We affectionately refer to it as More Squared Registry, which has data on about a quarter of the Medicare Advantage population in the United States. So it's a large sample. It's distributed similarly to the national sample when we look at the enrollment data. So it's highly representative of the national Medicare Advantage population. And we have all of their medical claims, pharmacy claims, just like you do in traditional fee-for-service. That data on Medicare Advantage has not really been available. So there's not been a lot of research done using on Medicare Advantage claims data. There's been a wealth and for decades of research done on Medicare fee-for-service. We also have access through a research data use agreement that Inovalon has with CMS to access the 100% Medicare fee-for-service, Parts A, B, medical claims, and Part D prescription drug data. And so the comparisons we did were from 2015 to 2017. And we started out the overall populations. We had about 1.5, almost 1.5 million Medicare Advantage patients, beneficiaries in the study. We had almost 8 million fee-for-service members, beneficiaries in the study. But when we did the matching, the linking, the propensity score matching, so we matched on all the critical characteristics, age, gender, census region, original reason for entitlement to Medicare, whether you joined at age 65 or you were under age 65 but you were disabled, dual eligible status, the chronic conditions that you had, and also the social risk factors. We also matched on social risk factor characteristics. So we truly are comparing similar populations. And so we ended up with 1,262,180 Medicare Advantage beneficiaries in the Medicare Advantage cohort, and a similar number because we did a one-to-one match in the fee-for-service population. Let me talk a minute about our data on social determinants of health, because I think it's important. The data that we have at Avalere is derived from Axiom, the company's name is Axiom, and their database is info-based geofiles. The difference here from using, say, American Community Survey data that is typically used in this type of research, or census block data, or zip code level data, is the granularity. There are 42,000 zip codes in the United States. And so if you think about a 5-digit zip code in Manhattan, let's say, you have a pretty disparate buckets of people. You have very wealthy people, you have very poor people. The effects of social determinants really sort of get lost or washed out. Even at the American Community Survey, which is a census block level, there are only 220,000 of those in the United States. And so there's still pretty large geographic areas with disparate folks. Our data is at the 9-digit zip code level. There are 30 million 9-digit zip codes in the United States. And so that's an average of about 5 households. So if you think about the 4 households around you, you probably look very much like them. And so this is a much more precise assignment of social risk factors. And so that is the data that we use for the social determinants of health. Next slide. So we will go into some of the study results. These are the clinical segments that we really focused on, and what our reporting here, we're going to focus on those bottom 3 cohorts, which are considered the high cost, high need cohorts. And so the disabled under 65, the bottom set of bars, you see that 20%, 20.3% of Medicare Advantage beneficiaries fell into that disabled cohort. And that is determined by by your reason for joining Medicare. Did you join under age 65 because you were disabled? It's essentially that population. There are fewer of those in the overall fee-for-service population, 17.5%. The next bucket of high cost, high need is the frail elderly cohort, and that cohort there are more of those members, Medicare beneficiaries in fee-for-service who are in the frail elderly cohort. To be in the frail elderly cohort, you had to be over age 65, and then there were some pretty strict requirements about you had to have several major chronic conditions, and we have the details of how those cohorts are specifically defined in the report. You can, and it's also in that paper. You also are required to have 2 or more frailty conditions. So frailty conditions are things like abnormal gait, frailty, weight loss, pressure ulcers, you had falls, you have difficulty walking, you use durable medical equipment like a wheelchair or a walker. So there's a list of frailty conditions, and you're required to have at least 2 of those. So we did see that in Medicare Advantage, those frailty conditions are coded far less often. We don't know why that's the case. So that could be part of the reason that fewer Medicare Advantage members ended up in that frail elderly cohort. But this is an older, more clinically complex population that is frail. The major complex chronic population, you're required to have multiple severe, what they consider severe chronic conditions. And again, they really use the 29 chronic conditions that are in the CMS chronic condition warehouse, with, using those definitions, and identified by expert, determination, 9 of those that are really severe chronic conditions. So you had to have, a number of those to get into that major complex chronic group. And the percentages are pretty similar there. There were only slightly fewer, 0.8 percentage points more members that fell into that cohort in fee-for-service. Most Medicare beneficiaries fall into the minor complex chronic group, which is not considered high cost, high need. They still have multiple chronic conditions, but they're not considered to be as severe, and they don't have as many of them. And then the simple chronic condition cohort has even fewer chronic conditions or severe, they're minor chronic conditions. There was also a relatively healthy bucket, but there were very few people in that cohort, so we didn't really spend a lot of time looking at that, and we didn't really see any differences in that relatively healthy group between Medicare Advantage and Medicare fee-for-service. So most Medicare beneficiaries fall into that minor complex chronic group. But we still have, big percentages of members in these high cost, high need cohorts that we are going to dig into a little bit more today. Next slide. So overall, this is now prior to the propensity score matching, so that we can get sort of an understanding of how these populations, as they exist, in the United States today, or this 2017, compare. And so they were similar in age. Their average age was about 83 years old, I think. They were similar in gender distribution, similar percentage of males and females in Medicare Advantage and fee-for-service. But we did see that Medicare Advantage beneficiaries were much more likely to belong to a racial ethnic minority group. There are more Blacks, more Hispanics, more Asians. They were more likely to be dual eligible than fee-for-service beneficiaries. They were more likely to live in an urban area. Medicare Advantage plans tend to be more concentrated in urban areas, whereas traditional fee-for-service, it is much, many more of those beneficiaries are in rural areas in the United States. And finally, the Medicare Advantage population was much more likely to be disabled. So to join Medicare under age 65 due to disability. We're going to look at the social risk factor comparison on the right, and we saw that Medicare Advantage beneficiaries were more likely to be low income. They were more likely to live in a neighborhood where a large percentage of the population lived below the federal poverty level. They were more likely to live alone. They're more likely to have less than a high school education. We actually have, buckets of the percent, in that 5, neighborhood area that have less than a high school education, some college, completed college. So they were much more likely to have less than a high school education. And they were also more likely to live in a neighborhood that had high unemployment rates. And those are rates of 8% or higher, I believe. So that's just a summary of some of the demographic and social risk factors that we compared in the overall populations before we did the propensity score matching. Obviously, after we did the propensity score match, our two populations are similar on all of these characteristics, right? Next slide. This is a couple of ways of looking at burden of illness in these two populations. And again, this is before we did the propensity score matching. The Charlson Comorbidity Index score is used widely in health research to assess burden of disease. It's a weighted score of disease severity that accounts for both the number and the severity of the chronic conditions that a patient has. And it uses 26 predefined chronic conditions. So it's a frequently used measure of burden of illness. What we have here is for both Medicare Advantage, the light blue, fee-for-service is dark blue, how they compared in each of the 3 years that we analyzed, 2015 to 2017. If you just focus on those light blue bars, which is Medicare Advantage, you see that the Medicare Advantage population is becoming more clinically severe over time. And in fact, in 2017, the Medicare Advantage population's comorbidity index score, average comorbidity index score is higher than it is in the fee-for-service population, indicating that they have a slightly higher burden of illness. On the right, we have the top 10 most prevalent chronic conditions in the two populations. Again, this is prior to matching. And you see that they're virtually identical and that the prevalence is virtually identical. You sometimes hear, people say, oh, the Medicare Advantage population isn't as, as sick, as ill. They don't have as many chronic conditions. We see that that's not, not the case. The most prevalent condition in the elderly population, the Medicare population, is hypertension, and the rates are virtually identical in the two populations. Hyperlipidemia is the next, most prevalent chronic condition in the Medicare population. Again, prevalence is virtually identical. Rheumatoid arthritis is the third most popular, a little bit higher in fee-for-service. Diabetes is fourth top chronic condition, slightly more diabetes, 34% compared to 30 31% in the fee-for-service population, but still very close. Chronic kidney disease, again, the rate slightly higher in Medicare Advantage. Cataracts is next in Medicare Advantage, whereas ischemic heart disease is the next condition. But you can see there's sort of the mix of conditions are the same, and the rates are pretty similar as we go down this list. Next slide. And this is just looking at those chronic, those clinical severity scores, those Charlson comorbidity scores in a little bit more detail from 2015 to 2017 in terms of what is the score. And the score is essentially counting how many chronic conditions you have. And if we look at that last set of bars, 5 or more chronic conditions, the light blue and the light green compare Medicare Advantage from 2015 to 2017. So what it's telling us is that in 2015, 42% of Medicare Advantage beneficiaries had 5 or more chronic conditions, but in 2017, 46% of Medicare Advantage beneficiaries had 5 or more chronic conditions. The trend is slightly different in fee-for-service. In 2015, 47% of fee-for-service beneficiaries had 5 or more chronic conditions, but in 2017, 46% had 5 or more chronic conditions. So, trending down a bit, but the severity of the Medicare Advantage population is definitely trending up. Next slide. So now we are going to switch to our actual study, our analysis, our results. And now you have to shift your mind to continuously remember that we are now comparing matched populations. So the differences in the two populations that we have just described that exist as those two populations are right now, as they have enrolled in Medicare Advantage or fee-for-service, are no longer present. We now have two similar populations, same age, same gender distribution, same chronic condition distribution, same social determinants distribution. So we are truly comparing apples to apples. So we're first going to look at a set of quality measures, and we've tried to group them into groups of measures that make sense, that kind of go together. And so the first three here are performance on diabetes care measures, on some of the diabetes care measures that are included in the Medicare Advantage 5-star ratings program. And so HbA1c testing is the first measure, and we see that Medicare Advantage beneficiaries are slightly more likely to get an HbA1c test. 91% of them, 91.4% of them got a test, compared to 88.3% of fee-for-service members. The second measure is, did you get an eye exam, a retinal exam, which is important to diabetic care, and far more Medicare Advantage beneficiaries got an eye exam, 78.3% compared to 62% of fee-for-service beneficiaries. The next measure is poor HbA1c control. Your HbA1c level is above 9%, And here Medicare Advantage looks slightly worse. 16.7% had poor HbA1c control compared to 15.8%. That number is not statistically significant, however. It's roughly a 2-point difference before you get into any statistically meaningful differences here. The last measure, we also see that fee-for-service beneficiaries did a little bit better on, and that is the proportion of patients with cardiovascular disease that were getting statin therapy, and 74% of fee-for-service beneficiaries compared to 67% of Medicare Advantage beneficiaries were getting that statin therapy, which is the evidence-based, practice. So here we are now breaking this out into those 3 high-cost, high-need cohorts, so that you can sort of see the differences on these same measures but in the high cost, high need cohorts. The overall, we saw the overall population, the numbers we just looked at in the last set of columns, in the last columns. And so if we look at HbA1c testing, for example, we see that in the overall populations, in the overall matched populations, and remember that was 1.2 million people in each of those populations, that there was a 4% difference, 4% more Medicare Advantage beneficiaries were getting that HbA1c test. But then if we start from the first high cost, high need bucket, the disabled under 65 cohort, we see that that's a 6% higher, 6% more of those who are disabled under 65 are actually getting that HbA1c test, but also 4% of the frail elderly, 4% more of the frail elderly, and 2% more only. So they're pretty close in terms of getting HbA1c test in that major complex chronic group. We're seeing some much bigger differences, though, in those that received an eye exam. Remember, we said that 26% more Medicare Advantage beneficiaries overall, if you look at that last number in the table, got an eye exam. But if we look at the disabled under 65 cohort, 56% more of those beneficiaries in that cohort were getting an eye exam compared to fee-for-service. So 79% of them got an eye exam compared to only roughly 51% of those in fee-for-service who are disabled under 65 received an eye exam. And so that's where we start to see the differences in these in treatment patterns in these high cost, high need cohorts. The poor HbA1c control, where we said actually, slightly higher, slightly more Medicare Advantage beneficiaries, 5% more were getting, had poor HbA1c control. But there is no difference in the disabled under 65 group. Same percentage has poor HbA1c. Slightly fewer in the frail elderly cohort in Medicare Advantage have poor HbA1c control, but in the major complex chronic group, 15% higher or more beneficiaries have poor HbA1c control in Medicare Advantage. And then again, we can see sort of the distribution of who's getting statin therapy, recommended statin therapy, and it's actually 10% fewer in the disabled under 65, 8% fewer in the frail elderly, and 5% fewer in the major complex group. Next slide. Another set of measures we looked at was performance on the initiation of alcohol and substance abuse treatment. And there are two measures. They're sort of paired measures. Initiation is the first step, but then once you initiate treatment, did you engage in treatment for the alcohol, drug, substance abuse? And there's an interesting, result here in that, far more Medicare Advantage beneficiaries are initiating treatment for alcohol and drug substance abuse, 67% compared to 51.9% of fee-for-service beneficiaries, but very similar rates are then engaging in treatment once they initiate treatment. And it's still a very low number though, right? 6% of the members who actually initiate treatment for alcohol or drug substance abuse get some follow-up treatment after that initial treatment. The bottom three measures are looking at use of high-risk medications and slightly higher use of high-risk medications. This only applies to the elderly. This measure, applies to people age 65 and older. And another a measure that's important given the opioid crisis that's still ongoing is patients currently prescribed opioids and benzodiazepines, and definitely more, 20.9% in fee-for-service are getting that not recommended treatment. So a higher rate is worse on this measure, right? Compared to 14.7% in Medicare Advantage. And then the last one is patients with rheumatoid arthritis who actually received, treatment, a disease-modifying treatment for arthritis, and slightly better performance there in fee-for-service. 77.6% are actually getting that recommended treatment for rheumatoid arthritis compared to about 75% of Medicare Advantage beneficiaries. Here it's interesting to look at the differences in the high cost, high need cohorts. For example, if you look to the far right in the top row, the initiation of alcohol, drug, substance abuse treatment was 29% higher in Medicare Advantage overall, but it was 46% higher in the major complex chronic group. And 12% higher in the frail elderly group and 18% higher in the disabled under 65 group. And you can also see that the rates are lower among the frail elderly that actually initiate alcohol, drug, substance abuse treatment. That's not, I think, a surprising finding, probably. But the rates are actually, very high in the major complex chronic group in Medicare Advantage compared to fee-for-service, 75% initiating treatment compared to 51% roughly in fee-for-service. The looking at the bottom groups is, remember that the high-risk medications only applies to 65 plus, so it doesn't apply to the disabled under 65 cohort. But overall, 16% lower use of high-risk medications in Medicare Advantage, and it was also 16% lower in the major complex chronic group, but it was only 7% lower, 7% difference in the frail elderly. And really that is, that frail elderly cohort is probably where you want to see the fewest of these high-risk medications being used, because the reason they're on the list is that they are considered to be dangerous. These medications are on the Beers list, right? That's sort of where they come from. We can see there's not big differences across the cohorts in the concurrently prescribed opioids and benzodiazepines, and there's not big differences across the cohorts for getting anti-rheumatic drugs. Now we're looking at a whole slew of preventive services, screening services, where we would hope, because of care coordination, we might see Medicare Advantage doing better. And indeed, as the Congresswoman mentioned at the outset of the call, we do see that in most of these measures that we looked at. The first measures, one of the exceptions, where 77% of fee-for-service members are getting a cholesterol screening compared to 75% of Medicare Advantage. Again, that's a 2 percentage points difference, so it's not, it's not likely to be statistically significant. But the percent that got a breast cancer screening is over, about 5 percentage points higher in Medicare Advantage. The percent that got a prostate cancer screening is slightly higher in Medicare Advantage. There's almost identical rates of patients who are getting a colonoscopy screening. Those rates are still only slightly over half of Medicare beneficiaries who are getting a colonoscopy screening. But depression screening, we see Medicare Advantage doing, significantly better. This is not only patients received a depression screen, but they also got a follow-up plan. And 86.3% of Medicare Advantage members get a depression screen, which is, pretty high number compared to only, to 72.5% of Medicare fee-for-service members. Flu vaccine, again, Medicare Advantage, 73% of those enrolled in a Medicare Advantage plan are getting a flu shot compared to 65.5%. We know that, we might not see every single flu shot. So, but we wouldn't expect those rates to be different, I think, across the two populations. Pneumonia vaccine, we probably are seeing that data, and the difference here is pretty striking. 73% of Medicare Advantage members are getting a pneumonia vaccination compared to slightly below 50% of fee-for-service beneficiaries. Almost 100%, 99.2% of Medicare Advantage beneficiaries are getting a falls risk assessment, which is one of those measures that may speak to coordinated care, better coordinated care, compared to 91%, which is still a high number, getting a falls risk assessment in fee-for-service. We see some interesting differences in these high-cost, high-need cohorts across these preventive screening and vaccination rates. So the pneumonia vaccine, for example, we don't see big differences, 49% overall, but 50% higher in the frail elderly, 52% higher in major complex chronic group in Medicare Advantage, getting that pneumonia vaccine. But if we look at the flu vaccine, which remember we saw 11% higher rate overall in this population, we see that it's a 14% higher rate among the disabled under 65 who are getting a flu vaccine. So almost 63% of the disabled under 65 Medicare Advantage members are getting a flu vaccine compared to only 55% of those in fee-for-service. The difference isn't as large among the frail elderly, where that flu vaccine, is obviously getting more attention and more important. And you see those rates are a lot higher too. 73.6% of the frail elderly in Medicare Advantage are getting a flu vaccine compared to about 70.5% of those in fee-for-service. And that's only a 4%, better rate, higher rate. And also 11% higher rate in that major complex chronic group. Same thing we're seeing we're seeing an interesting trend in breast cancer screening. So overall, if we look at that last column, 7% more Medicare Advantage members get a breast cancer screening or a mammogram. But if we look at the frail elderly, the rate is much higher. 14% more frail elderly in Medicare Advantage are getting a breast exam. And you can see that the rates who are getting that breast exam, though, are lower. Like, even if you compare the frail elderly, 63% are getting a breast exam in Medicare Advantage, compared to almost 74% of those Medicare Advantage members who are in that major complex chronic group. So there's a lot of data here in terms of, differences across these cohorts in terms of who's getting these vaccines, who's getting these screenings, and you really see the differences as to, what cohorts may not be getting as, the treatment that they should be getting, as well as seeing the differences that we're highlighting here, which is the difference between Medicare Advantage and fee-for-service. So now we're looking at potentially avoidable hospitalizations. These are relatively new quality measures, and they look at hospitalizations, but the quality measures have been specified so that they have tried to really isolate those that they are considered to be potentially preventable. And the measure is broken out into 3 measures, actually. One focuses on acute conditions, so you're hospitalized for a potentially avoidable acute condition, and you can see that the rate is higher in fee-for-service. Again, a higher rate is worse here because these are avoidable, potentially avoidable hospitalizations. The second measure is for chronic conditions, potentially avoidable hospitalizations for a condition that is chronic. And again, we're seeing a pretty big difference here, 12% rate in Medicare Advantage compared to a 20% rate of potentially avoidable hospitalizations for complications due to chronic conditions. Then the third measure is overall, combining for both acute and chronic. So overall, we see that the rate of potentially avoidable hospitalizations is about 13% in Medicare Advantage, and it's about 23% in Medicare fee-for-service, applying that same measure to the 2 populations. Another measure we looked at was, did you get appropriate care once you were released from the hospital? And so one of the measures here is the percent of patients that actually had a physician office visit within 14 days after they were discharged from the hospital. And almost 70% of Medicare Advantage beneficiaries see their doctor within 14 days after a hospitalization, compared to slightly under 58% of those who are in traditional fee-for-service. The final one is our well-known 30-day all-cause readmission rate. And this rate is pretty close for Medicare Advantage and fee-for-service, slightly higher in fee-for-service, 11% of 30-day all-cause readmissions compared to 10.4% in Medicare Advantage. This is breaking out then those same measures, but by the high cost, high need cohorts. And we didn't apply the avoidable hospitalizations measure to the disabled under 65 because it's specified for those who are 65 and older. But if we look at the difference in, say, let's look at the overall rate, 43% lower rate of potentially avoidable hospitalizations overall for both acute and chronic in Medicare Advantage. The rate was 13.3%, as we just saw, compared to 23.2%, but it was actually 35% lower in the frail elderly, so a little bit closer, rates of potentially avoidable hospitalizations, but 48% lower rate, almost a 50% lower rate of potentially avoidable hospitalizations among that major complex chronic group. So this is telling us that 11.9% of Medicare Advantage beneficiaries that have multiple complex chronic conditions are being admitted for what is considered to be potentially avoidable conditions, compared to almost 23% in Medicare fee-for-service. So that's a pretty striking difference in that cohort. I think, we see, let's just go back 1 second and just to look at the difference. So overall, those who are getting that follow-up care after they're hospitalized, overall 21% more in Medicare Advantage, but 42% more in the frail elderly group are actually getting that follow-up treatment after they are discharged from the hospital. Almost 74% are getting that follow-up visit compared to only 52% in Medicare fee-for-service among that frail elderly cohort. So that was an interesting finding.
Hi, Christy. Do you think, I'm just doing a quick time check here, do you think maybe we can summarize any of the remaining points and then go to some of the questions?
I think that's a great idea. Lots of data to get through here. What we'll quickly show here is that Medicare Advantage has fewer hospitalizations. These are hospitalizations per 1,000 patients, but more ER visits and more observation stays. When we translate that into costs, we see that the inpatient costs in Medicare Advantage are lower and the ER costs are slightly higher. Medicare Advantage also has lengths of stay that are shorter by about 1 day. Next slide. And we won't look at the detail here. Medicare Advantage has slightly more outpatient visits, so they're really using outpatient care, obviously more than hospitalizations, and their outpatient costs are therefore higher. Another interesting finding here we'll highlight quickly is that Medicare Advantage has higher primary care physician services costs, but they have lower specialty care physician services costs, so they're using specialists less often. Next slide. And we won't focus on the detail here. Spending more days in skilled nursing facilities in fee-for-service, spending more days in home health in fee-for-service, all of post-acute care, fee-for-service is using more often. We do see costs are higher in Medicare Advantage, however, in Medicare Advantage for skilled nursing facilities, but lower costs for home health or which is rehab facilities and long-term care. And we won't look at the detail. Higher spending on durable medical equipment in Medicare Advantage, and really the same number of unique medications being used in these two populations, and we would expect that to be the case. So here's one of the big findings is that overall spending in Medicare Advantage is about 15% lower when you combine both medical costs and pharmacy costs. Overall spending on average per person, $12,000 compared to $14,000 something in fee-for-service. The particularly striking in prescription drug costs were much lower in Medicare Advantage. And yeah, I think we're going to skip these key takeaways. I think y'all are going to make this information available. There's lots of takeaways here, obviously, to highlight. And so I'm going to turn it back to the Congresswoman, who's going to tell you how you can find out more about this study and all of the details here. And we're happy to answer questions as well.
Well, that's thank you so much, Christie, for that. There, I have to say, there's a lot of information in this report. There really is.
Yeah.
Sorry to have you speed through it, but it was a very robust study, a lot of findings, and some certainly interesting ones. The thing I'd like to do is we're going to. I'll close out at the end, but I'll just say it now, just in case, is that we're going to be sending you the report, so you get to see it yourself. And again, it's not one easy to breeze through, but really has so much good and important content. We also created a handy fact sheet, two of them actually, one that's a little more infographic, so really easy to see. And certainly you can look on our website, MedicareAlliance.org, for more information about this or any of our other resources, and happy to be in touch. But let's take a couple of minutes to take some questions. So, and let's start. Deborah, you have a few questions for us? Because I see some questions in our chat box and Q&A. Actually, so I don't know, we'll get through, but we'll try.
Sure, not a problem. So one of the questions that came up, Christie, is many of the measures show more positive outcomes for beneficiaries in Medicare Advantage. As a researcher, what can you reasonably infer about the results, and what do the results tell us?
Well, we do these comparison, utilization, quality measure comparison studies all the time. In this case, we really strove to make sure these populations were similar and comparable. So it doesn't necessarily speak to the whole populations, although we have that data as well, what the results were for utilization, quality measures for the entire populations. But we're showing you the matched, population. So I think these findings are very robust. They're very meaningful. We're applying exactly the same measure specifications. We're counting utilization exactly the same way. And we're using the same exact claims data, right? We're using all of the medical claims, all of the pharmacy claims. We're requiring it. We have strict enrollment requirements that we applied. So I think we can believe strongly in these results. Some of them still, I think, need further investigation. Why are prescription drug costs so much lower was one of the big questions that we had in Medicare Advantage. And we don't know the answer to that. We didn't dig under the covers, very much to uncover that. But I think the overall message and the strength of the message on, just literally 100 measures that we looked at and evaluated certainly shows that Medicare Advantage seems to be doing better in a lot of areas, but there are some areas where they look similar and some areas where they look slightly worse.
I mean, I can just make a comment too, and I'm not the researcher here, but just to share that we've seen this in our research. We, again, it's these aren't 100% numbers, but there's some really pretty stunning numbers. And again, this is following quality measures that are set by CMS. So as we see quality measures, you see the plans and providers changing the way they provide care, more outpatient, less hospitalizations. We know that they work hard on reaching out to help manage chronic conditions, but we saw some pretty good findings in frail, elderly, and disabled before, and we had not looked at those. So I think this isn't unusual. I mean, it's a very robust and important report, but it certainly is consistent with numerous reports done by others as well that show when you're looking at the measures of quality as indicated by the federal government, that the Dix takes these things, that a much better job is being done in many of these outcomes. And yes, always work to be done in some of them, but there's some really interesting findings here. So it's a lesson about whether an integrated care system, and this is the overall takeaway, is the integrated care system, and this may even apply to the difference in the costs, where you're having both the pharmacy side and the care management side and the clinical side really cooperating on this. We don't know that for a fact, but it seems like that suggests it. So it really is, it's a big takeaway as to the movement towards more integrated capitated financing, actually creating the very incentives that are intended to actually take care of patients' needs in a way that is preferable for the patient and possible. so we're pretty excited about this. Deborah, what's next?
Sorry, give me 1 second. So one of the other questions that came up was just more about methodology. So did everybody with fee-for-service Medicare also have prescription drug plans?
Yes. We required continuous enrollment for all 3 of the years that we looked at, 2015, 2016, 2017, in parts A, B, and D for fee-for-service. And then for the Medicare Advantage beneficiaries, we required enrollment in both, Medicare Advantage, the medical benefit, as well as the pharmacy benefit. So everyone had similar coverage.
Great. And then just a question about the propensity matching. When looking at propensity score matching, were people in Medicare Advantage, were they compared to people who may have had a Medicare spending limit with either Medicaid or Medigap policy?
We did not look at that. We basically matched on, everyone had part A, B, and D coverage, or medical and pharmacy coverage, and then we propensity score matched on the patient characteristics. So not on specific, other plans or coverages that they might have. So demographic characteristics, clinical characteristics, and socioeconomic characteristics, as well as geography, we matched on.
I would say even on the spending side, we didn't match. This is not the consumer spend; it's the spend that is
right.
in claims. So obviously that would be a big difference around Medigap if we didn't see Medigap, but we didn't look at that. We've looked at cost to consumers in other studies, but this one really is not looking at that either. And but you're right. Utilization would be different if you have Medigap or not, but we did not look at that. Yeah.
Yeah, we're looking at the full Medicare allowed amount. So it includes what's paid, and we also in fee for service we can see what portion that's paid for Medicare versus what is the patient responsibility. But we can't see that in Medicare Advantage because doesn't apply, right? So, but we did use the Medicare allowed amounts in the Medicare Advantage data as well. So again, we've got comparable costs.
But a note there too is that we don't really know what the plans pay these providers. So
We don't, right? Didn't use that.
So we
Right.
don't know that.
Yep.
It could be happening.
Yeah.
And so the spend, it's not really the spend, it's what we would consider comparable costs, because they could be spending more, actually, potentially.
Okay, and one more question here. Beyond the findings that we went through today, are there any striking multi-year trends in these measures?
So that is going to be a whole other report. So we'll have to have them hold their breath for that one, Congresswoman.
We've talked about that. We do have the data. The question is, do we do that or not, and how it's changed over time. We tend at BMA to look forward, and we do occasionally look at what the trends have been. And certainly we have seen some of the trends in terms of enrollment, as we've seen those too, in terms of who's enrolled, increasing numbers of duals and modest income beneficiaries, as well as racial minorities. So we know those trends, but we didn't study this. We didn't do that. There was enough data right here without actually adding it. And this is what happened over 3 years.
We did see a big trend also in prevalence of social determinants of health in the Medicare Advantage population, which I have looked at separately in a Commonwealth Fund study that I did. So there are some really interesting trends there. I think specifically, social determinants are so important now with COVID and the highlight on disparities. So, and we do see them growing in this population.
Do we have time for maybe one more? And then if we don't have, because I don't want to go over too much, I'm on the time here with 3 or 5, but let's take one more question. And then what we'd like to do is take these questions and we'll try and answer them offline for people. But Deborah, why don't you give us one more?
Okay. When talking about the falls assessments and depression screenings, were those done looking at the annual wellness visits, or were the measures just looking specifically for a falls assessment and depression screening?
Yeah, we're actually using the specification for the quality measure, and so we're using very specific codes that are have been validated, tested in those quality measures. So all the quality measures that we reviewed today are validated, NQF endorsed, CMS endorsed measures. Yeah, and we applied those specifications to the letter. So
but I assume it means we don't know what visit they found them in, right? I mean, it was in a wellness visit or some other kind of primary care visit, some other kind of.
Yeah, I can't remember the exact. Yeah, the measure spec. There are a number of codes that fit, the definition as to how you can get into that measure, into the numerator of that measure. But yeah, those specifications are available.
And again, this report, you'll get to look at it. Someone asked about whether these slides will be available. Actually, the report has this content in it. So you will have that available. And if there's some question we haven't answered, they can ask them there. But it's pretty robust number of charts and graphs and data. And yes, Christie's right. There's more data there to go after and to really to look at, which is something we look at. As you know, BMA has the Center for our research, which is called the Center for Innovation in Medicare Advantage, through which we do these things. We've worked with Avalere before, so there'll probably be more research coming out in the years ahead on this and other topics. But I think with that, I'm going to close and again thank Christie so much for her talent and her passion around these issues and providing so much data in today's presentation. And I think Deborah's keeping track of some of these questions in the chat. I think, my goodness, I think we have another 20, so we're not going to get to all of those, and we'll try and answer them if we can't. Maybe Avalere will be helpful to us and provide these answers. And with that, I want to thank everyone who participated in this webinar. And I'm going to say, all of you, if you're not already signed up for our policy alerts to get some of the research as we put it out, we will put you on our policy alert list and keep you up to date on the reports that we put out and the findings we report out, and some of the advocacy work that we do as well around, well, policy. We don't do it that way, but we'll stay in touch with you about the work that we do. If you're interested in our advocacy work, if you're an organization that's interested in working with us more directly, by all means, be in touch with us as well. So with that, again, be safe, be well, and we don't talk to you before the next set of holidays. Really be safe and enjoy. Bye-bye.
Thank you.